Welcome everyone to the November session of the Virtual Learning Collaborative titled Engaging Non-Traditional Partners and People with Lived Experience in Elimination Planning and Implementation, Part 1, made possible in partnership with the CDC Division of Viral Hepatitis. My name is Zakiya Grubbs, and I'm a manager on the hepatitis team at NASTAD and today's moderator. Joining us today are Dia Obonyo, Prevention Coordinator, Viral Hepatitis Program with the Kentucky Department of Public Health, and Sarah Ahmed, Communication and Community Engagement Projects Manager with the New York City Department of Health. The format for today's session is as follows. We will begin with presentations from Dia and Sarah and end with discussion and Q&As from the audience. Feel free to use the chat to introduce yourselves and jurisdiction and for your questions. Later this month, for the November 30th session, we will continue our conversation in the form of breakout sessions led by Dia, Sarah, and myself with a facilitator for each group to get to the nitty-gritty and ask questions and have a more candid conversation. So hopefully you all will be able to join us for that session as well. So let's get started, and I will turn it over to Dia.
Thanks, Zakiya.
Oh, I was supposed to advance my slides. I'm sorry. Here's what I just said. All right, and I'll stop sharing.
So thanks for letting me share Kentucky's experience with engaging non-traditional partners and people with lived experience during our elimination planning. So just a couple of background slides. The vast majority of our funding comes from the 2103 integrated funding for health departments from the CDC. We have a very small pot of money from our ELC grant for perinatal efforts. And our HIV branch supports us with a percentage of personnel costs, and we've gotten money from UK in the past, but we get no state funding at all. And so we're really hoping to be able to leverage this elimination plan to sort of advocate for that funding. So as many of you know, Kentucky is one of the top states in the nation most affected by hepatitis C. The rate of acute hepatitis C is double the national average, as you'll see in the first graph. That second graph is the same Kentucky line, but with 2 additional years of preliminary data added, and you can see the trajectory is not great there. So that's mainly driven by the use of non-sterile injection equipment in rural Appalachia, which covers roughly half our state. And in Kentucky, the 30 to 39 age group reports the highest incidence, and 20 to 29 is not far behind. So we have a very young population here. The average age at time of diagnosis was about 37. And in Kentucky, we get both positive and negative lab reports electronically. So we have good data there. And while acute and perinatal hepatitis C are reportable, chronic is not. So we really have to rely on modeling to get our estimates there. And so that's where we get our estimate of about 78,000 Kentuckians living with hepatitis C. So the viral hepatitis program, the Kentucky Department for Public Health, attempted elimination planning just prior to COVID. And so of course we got really delayed there. Most of the program was pulled full-time to COVID, as most of you were as well. And so we were happy to turn our attention back to hepatitis last year. So we really got our hepatitis elimination planning started in earnest toward the end of summer of last year of 2021. And we engaged in all these different strategies that you see here. So today I'll just talk about the 2 that are most salient to our topic. And so that's going to be our coalitions and some site visits that we did. So the first major thing that we really did when we set out to do our elimination planning was to form some stakeholder groups. There were no existing hepatitis coalitions in Kentucky. So we created a technical advisory committee and then a broader stakeholder coalition. We knew that at this point in time, we were not logistically able to do a true syndemic elimination plan as we would have liked to, but we wanted to keep our plan as syndemic focused as possible, with the hopes that in the near future we could really transition it to more of a syndemic elimination plan. And so we selected stakeholders with this in mind. Some of the individuals or agencies had been engaged in hepatitis work before, and some not at all. And they were just in areas that we knew needed to be at the table for these discussions. So, we engaged people that some we knew or had networked with, but there were a lot of just cold emails that went out, right? And sometimes you got a bite and sometimes you didn't. So, for example, overall, we got really good response from our emails, but there were some, there were some immigrant and refugee groups and some FQHCs, other treatment and recovery centers that I reached out to, and we just never got a response. But this was really still in the midst of COVID. And so I don't blame anybody for, not having the bandwidth to put another task on their plate. But we still have all these groups in mind, to try to engage with in the future, right? But for those that we did get on board, so who do we have? For our broader stakeholder coalition, we have a lot of different professional organizations represented, especially in the healthcare realm. So primary care, hospital, medical association. We've also got the Kentucky Rural Health Association, which runs a provider education and mentoring program specifically for hepatitis. We've got local health departments on board, a lot of advocacy organizations, others that focus on rural health, those that work in housing and homelessness, which is really important for these populations, Ryan White programs, reentry coalitions, and the Jailers Associations, because corrections is a big issue as well we need to work on. We've got a lot of community-based organizations, those that are working in HIV and with other types of infectious disease work. We've got the State Office for Health Equity, and then we've got patient advocates and people with lived experience, as well as NAMI, and of course, lots of SSPs. And on the technical side, we have a lot of researchers and medical providers from universities and major health systems throughout the state. We have various pharmacists from different programs, Medicaid services, which is really important for some of the things we need to work on. We've got community-based harm reduction, as well as the harm reduction at the state level. And then the Department for Behavioral Services, Developmental and Intellectual Disabilities they oversee all the treatment and recovery centers, the substance use treatment centers in the state. So we've got them on board as well. And then that last program, the KDAP, Kentucky AIDS Drug Assistance Program Reinvestment Program, KERP, is probably, just by sheer numbers, our largest partner. That organization is fairly new, but what they do is reinvest Ryan White dollars by embedding individuals throughout the state in harm reduction programs. And these individuals' jobs is to do HIV and hepatitis C testing and counseling and education. And in Kentucky, so one good thing that came out of the 2015 HIV outbreak in Scott County, Indiana, which is only 30 miles from our border, was that the Kentucky legislature passed legislation allowing for SSPs in the state. Each SSP has to be housed at a local health department and has to go through 3 different levels of local approval. But despite that, there is a very robust system of SSPs that has popped up in Kentucky. So we have more than 80 programs operating in over 60 counties. And there are KERP representatives at a lot of those different locations. And KERP is that organization I was talking about. And we relied fairly heavily on KERP to do this next thing we did, which was a series of site visits. So a really major part of our plan development that was important to us was to make sure that we had as much input from individuals with lived experience as possible. So we had some representation on our coalition, but we wanted to make sure that we had more adequate involvement. And so we knew that if we couldn't get people to come to us for coalitions and meetings, that we needed to go to them. So we set up a series of site visits throughout the state using our KERP contacts. And you can see the little stars on the map are those locations where we went. So within about a month's time, we traveled all over the state, and we spent the day at SSPs in those areas, and we just spoke to people. So we had in-depth conversations with staff and participants and peers. And we used some of our 2103 funding to purchase gift cards that we gave to participants to sort of compensate them for their time. So they were $20 gift cards for Walmart and Kroger. With the exception of one of the very rural counties, we were told beforehand that the Kroger and the Walmart are too far away and everyone goes to the Speedway there, the Speedway convenience store, because that's the only thing really accessible. And so for that particular county, we got Speedway gift cards for them just to make it more relevant to them. And so we had some of those areas were rural and some were urban and some were in between. So we had a pretty good representation there. And as we spoke to people, there were some really important themes that emerged. So we heard again and again about the myths and misinformation that's circulating in these populations of people who use drugs and in people who inject drugs. So a lot of people told us they thought that they could give hepatitis C to themselves. So they didn't have a really great understanding of transmission, where it comes from. Many of them thought that maybe it was treatable, but not curable. They still had just the outdated treatment guidelines, or maybe they only knew about the old medications that made you really sick and weren't very good. Or a lot of them were still under the impression that they had to completely abstain from any substance use for like 6 months or a year, which isn't the case. But to be fair, there's a few providers out there that still kind of adhere to those. But there's a lot of myths in that population. It was also apparent during our conversations that these participants really have a desire to be as healthy as they can be and to prevent harm to themselves and others. So they may be struggling with addiction, but they have a tremendous concern for their well-being and they're really doing the best they can. Many of the participants had been tested for hepatitis C. Some got tested regularly. And in fact, in one of the sites, a majority of the participants had not only been tested, they'd had hepatitis C and been treated and cured, which is great. But it brought up another issue that in these programs, these rapid point of care tests that are done for these particular populations, they're always going to come up positive, right? Because they've had hepatitis C. So it just indicated to us a need for a specialized strategy to really monitor reinfection in those types of populations. The participants really expressed a deep appreciation of the services offered at SSPs. They really knew the value of being able to get these sterile supplies in order to stay healthy. And they really had high praise for the staff at these SSPs as well, which in the past wasn't always the case. You know, people weren't always that nice to these populations, right? But here, the staff were described by the participants as people with such compassion and a really profound regard for human dignity. And that was certainly something that we witnessed while we were there on the ground and on site as well. Most participants knew acquaintances who use drugs that refused to use SSP services, either because of stigma related to drug use or stigma related to using SSP services, or because they fear having their name put into another system or fear that police are watching the building or other similar concerns. So we know that there's populations that aren't being reached by these programs as well. Many participants had vivid and harrowing experiences trying to utilize the healthcare system in the past. So many told about being denied for legitimate medical concerns because they had a history of drug use. One participant had some fingers cut off in a lawnmower, and he had some initial stitching and bandaging done, but a couple days later, his hand was just red and throbbing and painful. And so he went to his local ER, where he was immediately deemed drug seeking and turned away, and they didn't even change his bandages. So that individual went to a place where he felt safe and valued as a human, and that was his local SSP. So he went there, and the nurse there, they changed his bandages and did what they could for him and tried to get him to go back to the ER or another ER, but he, wouldn't do it. Why would you put yourself in that situation again and again, right? Another participant had been riding his bike to his local SSP for his weekly visit, and a car came and hit him. It was a hit and run and knocked him and his bike down a ravine. And he was able to get out and get his bike out. And he continued on to the SSP with what was probably a broken wrist. And he refused flat out to go to the ER altogether. Because of his past experiences. So the staff at the SSP, they rigged up a splint the best they could, tried to get him to go to, the emergency services. But again, because of his past, history of discrimination, he wasn't going to put himself in that situation. And so the staff and nurses at SSPs had a lot of stories about, doing wound care, the normal stuff, but also services that go well above and beyond, right? And so everything that we heard during our visits really helped us to contextualize our priorities while developing our elimination plan. So each of these themes has really strong implications for how we should go about elimination in these populations, right? And so for our actual plan, we thought it was really important to spell out our values, which are harm reduction, really focusing on those priority populations, centering those voices that we heard and that we continue to hear from, right? Those voices with lived experience, health equity and inclusion of historically excluded groups, and also a status neutral approach for people who use drugs and others at increased risk for infection. And so status neutral is used in HIV testing, right? And it proposes engaging individuals in care and support regardless of the test result. And we think this is very applicable for hepatitis C testing in these populations as well. And so what are our priority populations? So there are people who use drugs, incarcerated or formerly incarcerated individuals. In Kentucky, we have a large percentage of individuals that just cycle in and out of the justice system, right? Historically excluded racial and ethnic populations. Kentucky is a very white state, as we know, but for our populations of other racial and ethnic populations, even though our rates may be lower, we know that the outcomes for these individuals are often worse. So we have to make sure we keep a focus there as well. Baby boomers. So we very much have that bimodal distribution of hepatitis C, so the young populations and the baby boomers. And in Kentucky, oftentimes the baby boomer population are also populations that use drugs as well. So we have to keep them in focus as well. We have high rates of women of childbearing age with hepatitis C or exposure to hepatitis C, and high rates of pregnant women and pregnant persons who are either have been exposed or have hepatitis C. And unfortunately for a lot of those women, a high percentage of their children, when they do give birth, will end up in the foster care system. So in the foster care system, we have large numbers of children that have been exposed to hepatitis C. People with prior infection, we have to keep monitoring reinfection rates. And because Kentucky is a pretty rural state, we also have to keep our focus there, right? And so our goals in the plan largely mirror those in the National Strategic Plan, with the exception of the National Plan has that fifth goal, which is just sort of disparity, equity oriented. And we didn't want that as a separate goal. We wanted to infuse that equity lens throughout all of our goals and our entire plan. And one of the ways we do that is by really delving into that qualitative data, talking to people. Don't just get mired in statistics and numbers, but really dig in and find out where our disparities are, where we need to be focusing, right? And so our plan was officially released in August, so it's just a few months old. And what our next steps are, we're keeping our coalitions involved. So right now, those coalitions are slated for at least annual meetings, but we're also going to pull them into special projects along the way. And the way that we're going to keep them involved is evolving over time as we learn more, as we learn what we need to be doing, right? And we've recently put together a smaller, more dedicated working group made up largely of people from those coalitions, but a few others as well. And that group is really working to hammer out the monitoring and evaluation piece. They're working to identify gaps and pinpoint barriers. And they're also looking into working on specific areas like Medicaid policy and corrections issues. of which there are many, and really outline how organizations can implement this plan within their communities. And then, of course, we really want to leverage this plan for that additional funding that we need. So that is all that I have.
Thank you, Dia. Sarah, you ready?
Yes, I'm all set. I wasn't sure. Thank you. I enjoyed that presentation, Dia. As I pull up to share my screen. And it was exciting. I just want to say congratulations again. I know how hard it is to put out an elimination plan as my PowerPoint loads. And it's exciting to see that you'll be touching on some points that I will also be touching on in terms of engaging non-traditional partners. It says I cannot share my screen. Let me try one more time. Can anyone see slides? I cannot see the slides. Okay, I saw Dia's face. That's a no. Great. Give me 1 second.
Yes, it says you started screen sharing, but that's all we can see.
Let me stop. Okay. Thank you all for your patience.
If you want, Sarah, you can email it to us and we can share it.
Mm-hmm.
All right.
It's just moving a bit slowly. Thank you everyone for their patience. Okay. I'm hoping y'all can see my screen now.
Yay!
Yes.
Okay, great. Whew. It's like, what is happening? Thank you all so much. All right, let's get started. So my name is Sarah Ahmed. I am the Communications and Community Engagement Programs Manager with the Viral Hepatitis Program at the New York City Health Department. And I manage our Hep-Free NYC network, which has many coalitions and initiatives under it, but it is the network building capacity to prevent, manage, and treat hepatitis B and C in New York City. So I'm going to start. My presentation will primarily be focusing on sustaining viral hepatitis coalitions as it relates to engaging non-traditional partners. So the two main components of sustaining a coalition is building the momentum and then maintaining it and keeping it going. So my windows are malfunctioning. So if you're starting a coalition, you may or may not have had your first meeting. I know many of us are either almost complete with elimination planning, but building off our elimination plans, or if you're starting out a coalition, how are we building the momentum within our coalitions to achieve our goals? How do we ensure that our goals benefit our partners? One example that Dia shared was gift cards. It's something that's super small, but it's a great way to invite participation and also thank people for their participation. Making sure that we have partners that align with our goals is really critical. Or if your coalition is newer and you've built up some momentum, now what? You've had your first few meetings, you might have published your elimination plan. How are we going to maintain the excitement of the elimination plan or getting to an elimination plan and implementing it? Are we seeking out partners that require more connection and consistency? Often non-traditional partners are not the first ones that we usually go to, but their work aligns with our work in terms of viral hepatitis elimination. And so how are we building those collaborations? And how are we evolving and creating different mechanisms for meaningful engagement? We can do the same thing repeatedly, but often community members, partners, and people with lived experience want to further their own lives and further their involvement in terms of what elimination looks like. Excuse me. And of course, I won't have time to answer all of those questions, but like Zakiya said, in our next VLC, we'll have breakout rooms to get into more of the nitty gritty and troubleshoot more of your questions. So a little bit of background around New York City, hepatitis B and C prevalence, 243,000 New Yorkers are living with hepatitis B. This number has actually gone up, and 91,000 New Yorkers are living with hepatitis C in New York City. The Hep Free NYC has two main coalitions. We have the New York City Hep B Coalition, which was founded after our Hep C task force. It was founded in 2009 by the health department and community stakeholders after we received some grant funding. It is no longer grant funded, but we have continued the Hepatitis B Coalition. And we also have the New York City Hep C task force, which was founded in 2004 by service providers working with affected communities in the South Bronx. So the community providers gathered and then the health department later joined, and then we merged the Hep B Coalition and the Hep C task force. So in terms of building momentum and creating the two main components, at least for us at Hep Free NYC, is creating meaningful engagement and empowering our community partners. Creating meaningful engagement can look different ways. So one of the ways that we have started with at our base, our meaningful engagement involves our coalition work. We have it open-ended, anyone can join any of the meetings. And so at a base, we are trying to create as meaningful engagement as possible within those coalition meetings. And so the biggest thing that we tend to try to address in those meetings is what do community members need and what can the health department provide? Sometimes there are more stipulations around what health department provides than what the community needs and what we can actually provide and give them. However, it's very important for us to be clear on those boundaries around what we can provide and making sure we're not over-promising because we want to make sure we can maintain and keep our commitments. And that's a key part of building meaningful engagement is what can we provide because we don't want to over-promise, as I said. And being able to address specific needs that we know we can respond to is key in creating that engagement. Engaging partners with lived experience in particular is key for not only the legitimacy of your work in your coalition, but also it's your lifeline into what's happening in the community. So making sure that people with lived experience are participating allows you to have an ongoing, continuous flow of information for you to be able to create meaningful engagement. In terms of empowering community partners, who is most impacted by this work? As we said, folks with lived experience, there are folks working in the field, family members, community members, advocates, researchers. There's a host of people who are impacted by this work and who are excited and passionate about this work. And so how are we involving them in the coalition? We can just have them come listen to us, but we can is one of the earlier options, and in terms of providing resources and things like that. But one of the ways that we have empowered our community members is providing skill building and leadership opportunities. For example, for people with lived experience in New York City, we often find that people with lived experience may not want to share those experiences on larger platforms. So for example, if we want to spotlight them on social media or have them present at a coalition meeting, we find that there is more resistance in those spaces to do that. However, for example, Hep B United, one of our national community partners, has the Just Be Storytelling Workshop. And we often refer Hep patients who are living with hepatitis B to join the Hep B United workshop. Not only does that put them on a national platform, but it also provides skill building and leadership for them to develop their skills and then come back to New York City, where we can work with them to present at different coalition meetings, have them at health fairs, et cetera, but then also how can we quote them in press releases and further legitimize and encourage our state partners or city government to increase our funding, et cetera, or like allocate resources differently. So focusing on who's most impacted by the work, and then providing skill building and leadership opportunities, as well as different platforms that they can grow and utilize their experience or skills, is really important in empowering the community partners. In terms of more established community partners and non-traditional partners, they have a wealth of information. So we often have partners who may seem more non-traditional present on their current work, especially as it relates to hepatitis B or C in New York City. And this exposes all of our hepatitis B and C partners to these organizations who may be doing non-traditional work, but who we know the patients will be able to benefit from. So, and empowering them to present at coalition meetings, which is one of the ways that we hear that they often enjoy, provides networking, allows them to build their skills in leadership, allows them to be held as a model within the community, et cetera. So there are many different ways that having partners present on their existing work, we don't have to reinvent the wheel. Some people are already doing the work, big or small, and having them present on that work is very supportive for overall hepatitis elimination. We also do this through a variety of community engagement strategies. So as I said, we try to build meaningful engagement in different ways. So as I said, we often use our coalition meetings, but we also have special events. We do press releases, we host annual events for Hepatitis Awareness Month, and we often try to specifically engage people of lived experience and have them present or speak at City Hall, et cetera, and those kinds of events. And we have found that those are events where they really appreciate and find themselves meaningful to be able to share their lived experience to people who have power and who can allocate resources differently. Trainings is a way that we build skills within clinicians and within patient navigators. So, and we also support people with lived experience through patient navigation programming, so that way they can support themselves and as well as educate people who may be newly or reinfected. We have a website with resources that can engage new folks as well as folks coming in. We are consistent with our email communications and newsletters, as well as social media in terms of outreaching to non-traditional partners. And we develop projects with our community partners that I'll speak about a little bit later on, but we build out projects with different partners. And that's a way to encourage leadership. If a partner has an idea, we are ready to roll with it. If they have capacity to do it, what better way to show them that we value them if we can make even any part of that project happen. So maintaining a momentum. This is like if you've already had a few meetings, if you've had meetings for a few years, your established coalition, how to grow and evolve. And consistency and accountability are key points. So you've maintained coalition for a while, you might be hosting meetings in a similar way. How growing and evolving means sometimes changing your structure, sometimes switching up the style of the meetings, focusing on meeting facilitation more. So this could be like a sticky area in terms of maintaining momentum, especially with partners that maybe have already done the Just Be storytelling project, and you might be wanting to engage more non-traditional partners. How do you grow and evolve and bring them on in a meaningful way? So one of the ways that we do that at HEP-NYC is through our committees and initiatives. Our committees and initiatives is our area of growth. The committees and initiative evolve almost every year, sometimes every 6 months, based on the needs of the community. And they allow us to implement action items quickly. So by developing small work groups of at minimum 5 people, we can start acting on any specific requests. We can engage specific people who are focused, for example, on elimination planning. Not the entire coalition may be interested, and not everyone you meet will be interested, but how can we specifically engage people who are specifically interested, like I said, in elimination planning. All of the committees, because they're smaller work groups, allow for more regular updates than for the larger coalition. Nothing is beyond the understanding of our partners. And we love the terminology, nothing is nothing about us without us, because, for example, in our coalition against hepatitis with people of African origin, all of the work that we do from start to finish, they're aware of every step in the process. And this builds meaningful engagement and keeps them in communication with us, but also it lets them know on a one-on-one basis that their feedback is valuable to us. We also invite partners to guide future meetings and conversations. So some of these newer initiatives, for example, the New York Hep Clinical Collaborative, as well as the South Asian Hepatitis Initiative, were started by community members who were reflecting to us that there was needs in the community, and how could we address that? And so on a regular basis, formally or informally polling people who are interested or your coalition members, asking them, what are the key communities that you're interested in? Are there any project ideas that you have? And then acting on them is a way to bring people on and evolve, grow, reflect that consistency and accountability. Another item for consistency and accountability is action items. We're really big on action items. We want at the start of every meeting or interaction that we have an action item that people will come away with. Whether that action item is, make sure you share this resource with your community members, or here is the date of the next meeting, please attend. Leaving people with an action item encourages accountability on both ends. We will host the meeting and we're asking you to attend, and it can be as simple as that, or and building that level of consistency and accountability allows for, we would like feedback on our elimination plan, or we would like feedback on our coalition meeting. Would you please share it? Because as you know, we have a rapport of consistency and accountability. And to share with that, we in January, I believed, we started talking about a hepatitis coalition building toolkit, which addresses some of these topics more in depth. The hepatitis coalition building toolkit is about 14 pages from start to finish. So it's a really quick read, but we wanted to put some of this on paper, as well as have other jurisdictions that have established coalitions pitch in and see how we can support elimination planning through coalitions throughout the country. So the 3 main topics are coalition building, strategic and elimination planning, as well as implementation and evaluation. It also, I believe, covers different types of partnerships. It covers engaging non-traditional partners, engaging people with lived experience, developing goals, objectives, and strategies. And at the end, there are lists of resources, everything from other contact information for other jurisdictions, as well as different resources. The outline of the toolkit was based on the Emergent Strategy Core Principles by Adrienne Marie Brown. These principles guided some of the flow of our work and can be used as principles in your coalition or elimination planning meetings. And some of this is reflected throughout we have little quotes from different community members and jurisdictions across the country reflected in each of these quotes. This is a little preview of the toolkit. This section is on meeting facilitation and hosting successful meeting, as well as tools for engagement and ownership, both on behalf of health departments. So here it says, highly recommend a facilitator, make it their plan, be consistent on meetings. As I said, consistency is key. Urgency is better to keep the momentum, and give them responsibility and freedom. And that comes from Tara McKinney from Missouri. So thank you so much. Stay in touch. I included some of our contact information, but I will also be speaking with some of y'all in 2 weeks. Thank you.
All right. Thank you so much, Sarah and Dia, for your presentations. It's a lot of things to think about and a lot of things to consider when we're working on developing and maintaining our coalitions, especially working on our plans. If anyone wanted to come off mute and ask any questions for our presenters, feel free. I did see Amelia had a question in the chat if you want to come off mute.
Thanks. I hope you can hear me okay. I'm outside right now, but yeah, I mean, we've been kind of really slowly developing our elimination plan. And I feel like my group is like unofficially a coalition that I run, but I'm just curious if either of you or others on the call have seen different ways to get feedback on your plan. I mean, I think just sending it out on an email and asking for feedback is not the most fruitful. I kind of put in the chat, I try to, like, as we've been picking away at it, say, you know, if you can give me feedback on these specific items, you know, and so it's not like an overwhelming, like 30-page document that they have to read, but even then, not really getting a lot of feedback. We have a meeting in a couple weeks, and I'm thinking of maybe having everyone kind of go into breakout rooms and talk in smaller groups and then bring feedback. But definitely curious for other ideas to, and obviously this is like really specific to the written plan, but getting feedback on that.
Sure. So what we did when we had coalition meetings, we did a lot of breakouts, and then we came back together for larger discussions. We used tools like Jamboard, something that could really help us get people's ideas and brainstorming out there, but without the chaos of like having too many. And then once we had a draft of the plan, we had what we called a public comment period. And so we had 2 or 3 weeks, I don't remember exactly, where we built a red cap survey and then had the plan available. And we sent that out to all the coalition members. We sent it out to all local health department directors. We sent it out to all those professional organizations, just every, you know, listserv we can think of, and asked people to share it widely. And then, you know, had those couple of weeks where people could go to the red cap link and submit any feedback they had on it. So, you know, you probably sent that to hundreds and hundreds and hundreds of people and get, you know, maybe 10 responses. So it's always going to sort of be that way. But I think probably quality over quantity, you know, is better when you're getting feedback on those plans anyway.
Thanks, Tia.
Just to also follow up, we also use breakout rooms and we also use Jamboard. But I think the thing that helped the most was consistency. So at any meeting that we had, we put the elimination plan on the agenda. Any meeting with external partners, whether it was through our practice facilitation program with clinicians or patient navigators, we put it on the agenda, and that allowed us to expand how many people that we were reaching. But the breakout rooms 100% help. I would recommend we had internal health department staff facilitate. So we had about 5 or 6 breakout rooms where we had health department staff and we had them ask very specific questions. So not everyone in the team had like fully read all of the elimination plan or worked on it, but we were able to say like, these are the guiding questions that you ask. And so we can get specific feedback versus sometimes, you can get sidetracked based on needs and everything. So if you have specific questions, it was helpful to have our folks ask questions and then take notes on screen. So that way people could see that we were listening to them and we were tracking it somewhere. Because sometimes if you have a small breakout group, they don't know that you're actually tracking the feedback. So that was one point that we heard was helpful and I think encourage more participation.
That's awesome. Thank you.
Thank you all. Anyone else on the call had any thoughts they wanted to share towards Amelia's question?
Okay, hi.
Yes, go ahead, please.
Yeah, okay. Good evening from Tanzania, East Africa. My name is Shaibu Issa. I'm a hepatitis B patient and live the experience who doing advocacy from Tanzania, insist people to be tested, to get vaccine and to experience of hepatitis B. From losing my brother, I want to ask if this movement it consists for the people from Africa or it's just America only, because of hepatitis B in Africa is large, and when you check the number, the half of population who have been affected with HBV, we are in Africa. So the place that need active movement to address the problem and eliminate it. So I want to know that if we are going to be included, and I'm ready to be included because I'm currently doing very actively working of advocacy and make sure that we saving people from liver cancer, because I don't want to see many more brothers and sisters die for the liver cancer, and myself too. Thank you.
Oh, thank you for that question and comment. Most of the organizations that we work with are for U.S. jurisdictions, so states, counties, and territories. But there is some work, and I think Sarah had mentioned that there is some work focused on folks living in the states of African origin, but we're mostly just focused on folks living in the United States. But I can get you some resources for global programs that may be helpful. Thank you. Do you have any other questions from the group? Okay. Well, I guess I have a question for our presenters and also for the group. I like how you all have been working on, engaging folks with lived experience, and I guess we say this a lot, but meeting folks where they are. But I think that's really important for gaining trust, especially as you all are government employees, and making sure that folks feel like they can actually ask you all for the things that they need and have trust that you all will actually work towards getting them as much as you can, given limitations. So I know you all mentioned like going out via to the SSPs around the state and not just asking folks, to come in to the Capitol, to the health department to come and talk. And also, Sarah, your points about being very specific about what you all can provide and how that reacts to what the community is asking for. I was wondering if y'all had any other tips or things of how you've been able to build trust, and also for anyone in the room, if y'all would like to answer as well.
A lot of what we've been doing, and really my job has been, is really building partnerships with those community organizations and other agencies out there, because those are the people that are working with these folks, you know, on the ground, one-on-one every day. You know, they know what's going on in their local communities, and they really have that rapport directly with the people with lived experience, right? So yes, I sit in an office, you know, at the state capitol, but those are community partners on the ground. They know, they're in the local communities and they know what's going on. And it's vital for me, you know, what do I know sitting in my office? It's vital that I have this, you know, good connection with our community partners, because that's really the direct link to where we need to be. So whenever we can, yes, I'll go directly out, but it's vital that I always have that, you know, that good rapport and the partnerships and the engagement with our community-based organizations and other agencies around the state.
The thing that I would add is investment in the person. So we want viral hepatitis elimination, but the person has other needs and often more pressing needs. We even find it often with our patients that viral hepatitis is not the top of their list of concerns to address. And so one of the reasons we actually really ramped up our skill building curricula through trainings and even community, like enabling someone to be able to speak at a city hall meeting. While we as a health department can't do that, it's incredibly important to build up the skill building, because this impacts their livelihood. It affects how they can show up for our elimination planning and for our coalition meetings if they can't continue to advance in their career. So part of the reason, I mean, it's as simple as like, you know, learning point of care testing, or learning more advanced information about hepatitis B and C, being able to offering for the patient navigators to be able to participate with the clinicians so that way they can better serve their patients, but they're also learning in their process and they're feeling empowered in the process. So that was one of the key ways to provide leadership and skill building, has allowed for us to meaningfully engage with people with lived experience, because we reflected that we value them beyond them having a positive hepatitis C test and getting cured. Like, they're not just a number. So having as much as we could with our re-entry program, for a period of time, we provided burner cell phones for people when they first got out. And our one requirement was that they had to answer the phone when we tried to do like some contact tracing and trying to provide resources. But in that, we also would invite them to coalition meetings, et cetera. But offering them a service, especially with folks with lived experience and with partners who are non-traditional partners, I think as much as possible, giving them a platform. That was really key. Like, if they knew that, 200 partners or even 50 partners at a smaller meeting was going to be able to hear about the services that they provided, and maybe they would get more patients, that felt like a win to them. So meeting them where they're at also means like we can actually support you. And sometimes we can't do advocacy work and we can't do certain things as the health department, but there are many things that we can do if we think a little bit creatively.
Thank you all for that. I see, Carrie, you had a comment in the chat. I don't know if you wanted to say it aloud.
Hello, can you hear me?
Hello.
Yeah, my name is Carrie Escovedo. I work at the California Department of Public Health, STD control branch. Before I worked in public health, CBO nonprofits, peer-led organizations, and just something that I found that, you know, when we would hire like a lot of peers, right? Community members to do work with our communities we were working with, but I would. Can you hear me? Here, let's try this. Can you hear me now? Okay. Yeah, just the role of peers in our communities and nonprofits and CBOs is, you know, often just an excuse for agencies and their funders to underpay those people. compared to their professional counterparts. So in order to get the trust of our community members, I really think it's important for, when we hire these community members to work within those communities, to make sure that they're getting compensated in a way that's comparable to their professional counterparts, because their lived experience is legitimate. And so when we're not paying them enough, then that indicates that, this is lip service. We're not paying them what their experience is worth, compared to somebody who maybe went to school for it. So that's all I wanted to suggest.
Yes, thank you for that. And I know sometimes there's barriers and a bureaucracy about minimum education requirements and things like that. So just trying to, I guess, manage that and work through those bureaucratic things is a challenge as well. But it's definitely needed, and it's definitely a vital piece of the pie. Do you have any other questions or comments from the group? All right. Okay. I guess we have a few minutes, but I guess we can end early. I do want to remind you all that we will be having, yes, and also, those drug background checks is another issue. Yeah. Oh, there's just some comments in the chat about removing barriers around hiring, especially in the government agency. But thank you all so much for joining today. I did want to remind you all that we will be meeting again on November 30th at 3 p.m. Eastern to continue this conversation in breakout groups. So it'll be more of an opportunity to discuss with the panelists and myself about some of the things that you all are doing with your coalition. So please bring all your questions and bring all your expertise, and we can kind of workshop through any issues that folks are having and all of that. So thank you all so much. Thank you again to our panelists for such great information. This has been really amazing. So thank you all. I know that there's a holiday in between, so y'all please eat a lot of turkey and enjoy yourselves and enjoy being around friends and family. So thank you all and have a good rest of your week.
Thank you.
Thanks.
Thank you.